We're now opening the panel, and that means I'm kindly inviting all panelists on stage. So can we please have here on the floor, on the stage, Michael. Can you join us, please? Michael Adelhardt from the GIZ in Germany. Heidi Boncana from the Global Digital Health Network in the US. Nadi Kaonga, also from the US, from citiesRISE. Professor Dr. Titus Kühne from the Charité University Hospital, and also from the, what's the English name? The German Heart Institute. Thank you. That's why we have name tags. And Natalia from the GSMA. And Norman, of course, because he's the co-host of the session. You can... I sit here. Could you maybe change? Because, thank you. It's quite good to, as the host, to have everything here. So we have, just for a setup, we have 4 microphones. And we now have a bit more than an hour of time to discuss the challenges. But before I do that, I'm glad to introduce all you here to the audience who is on stage. So, Dr. Michael Adelhardt is the new head of the GIZ Competence Center for Health, Social Protection and Inclusion based in Eschborn in Germany. And while I'm doing these intros, please feel free to open the water bottles and pass the openers around as well. Thank you. And a piece of paper. Okay. And, excuse me. Michael started his work in development cooperation in 1989 as a medical doctor, working as a physician and district medical officer in the Zimbabwean health system for 6 years. After earning a public health degree, he was heading various national and global health programs financed by the DFID, the EC and the German government, with duty stations in Kenya, the Philippines and GIZ in Germany. Michael also holds a medical doctorate and a Master of Science in Health Systems Management with a focus on health economics. He worked for 5 years with the World Health Organization in Geneva and 3 years with the World Bank in Washington, in both assignments as coordinator of the PH4 network, a global network for universal health coverage and social protection, and now head of GIZ Competence for Health. Welcome on stage. Miss Heidi Boncana, right beside him. You're the co-chair of the Global Health Network, Global Digital Health Network. As a senior program officer for ICT and innovation at Johns Hopkins, Bloomberg School of Health, Center for Communication Programs, her work focuses on using digital health, ICTs, electronic health and mobile health tools, platforms and partnership to support frontline health workers, health systems, strengthening and improved governance in low and middle income countries, to lessen health disparities, drive behavior change, improve access to information and quality care in resource-poor areas of the world, particularly for women and girls. Under Usaid flagship Knowledge Management Health Project, K4 Health, she serves as a co-chair of the Global Digital Health Network, a global community of practice for 3,000 health technologists. The network convenes monthly meetings in Washington, D.C. and remotely, as well as hosts an annual conference, the Global Digital Health Forum, previously called the mHealth Summit. I've been there, by the way, in Washington. And other events to connect people to each other and to digital health resources. Mrs. Boncana's background includes experience in nearly 50 countries with expertise in public health communications, social and behavior change communication, advocacy, landscape assessments, capacity building, partnership coordination and resource mobilization, strategic knowledge and management, and documentary reporting. Okay. Right beside her, Ms. Nadi Kaonga from the organization citiesRISE, also from the United States of America. And she is an independent technical advisor in digital health and health systems strengthening, who is currently serving as the technology advisor to citiesRISE, a global collaborative movement that seeks to transform mental health. She has also worked extensively in her home country of Malawi, as well as in over a dozen other locations throughout the world, managing, implementing, and evaluating projects that have included the prevention of mother-to-child transmissions of HIV/AIDS, emergency medical response, and digital health. She has served as a consultant to organizations including the United Nations Foundation, UNICEF, Malaria No More, and the Global Development Incubator, and more recently had been the Senior Program Manager and Senior Technical Advisor, Interim Deputy Director of Health Enabled. She is a graduate of the Columbia University, the Johns Hopkins Bloomberg School of Public Health, and the Tufts University Sackler Graduate School of Biomedical Sciences. She's currently a doctoral candidate in the Doctor of Medicine program at the Tufts University School of Medicine. Okay, this side has been covered, Norman. Good job so far. Really, really interesting people here. Besides here on this side, Professor Dr. Titus Kühne is a cardiologist, professor of cardiac imaging at the German Heart Institute, and the director of the Institute for Computer-Assisted Medicine at the Charité Hospital, University Hospital here in Berlin. The institute is focusing on innovation in digital health and is the first of its kind located at a medical university. In addition, Professor Kühne is the CEO of the company eMedical Communication that is specialized on developing and managing new ICT health products for industry and governments. Right beside him, we have Miss Natalia Pshenichnaya. I was close. This is why we call ourselves the first names here on the panel. She is the head of M-Nutrition and M-Health at GSMA. And Natalia is comprising of M-Health and M-Agri programs there at GSMA. The GSMA represents the interests of mobile operators worldwide, uniting nearly 800 operators with more than 300 companies in the broader mobile ecosystem, including handset and device makers, software companies, equipment providers, and internet companies, as well as organizations in adjacent industry sectors. So you have this association that actually makes everything possible regarding smartphones and stuff like that.
It's more than smartphones.
Even more.
It's work
like
on like common
digital
standards, rural coverage, making sure we have connectivity in most places.
Wow.
Yeah.
And you're also overseeing the portfolio of projects across Africa and Asia, as well as investment decisions and implementation, support to members and partners. She has been working on mobile solutions for rural segments since 2010. And prior to working with GSMA, Natalia has worked with a mobile operator Megaphone in Russia, specializing in WHS development and marketing. She held an MBA from the University of Oxford and a Master of Science in Economics from the University of St. Petersburg, Russia. All right. That's it so far. My goodness, great panelists. Okay, now please, let's start with your introductory speech. You said in your speech, you named a couple of challenges regarding digital health in Mali. You spoke of sustainability. Can you explain to us, with the example of Ebola, for example, how did you overcome these challenges that you were facing with this outbreak there in digital health?
Thank you very much. You know, this Ebola outbreak shows that many of our country systems are very weak. And then when we faced that, the country was very, if I can say, very proactive and react immediately, using health workers in the ground, in the field. Because you know, these people in our countries, neighboring countries, there is not a clear entry point in borders, because there people can enter in many ways. So we need help from community health workers and also community leaders. So doing that, we try to use cell phones to make connection with a kind of Ebola center we put in place and make linkage with all these persons. It was not very clearly established, but this shows us that this is a way we can strengthen it and make it more formal and organize it better, and it can help in the future. Because what you are talking here now is not everything is perfect. We are talking about the future. What are the small things we are doing this way? We have to pull all these things to learn lesson from that and put on place something very strong. And this help to have early information of suspects, not confirmed cases, and this avoid many things because at the right time we came and to try to solve the problems.
Yeah.
This is a very crucial thing during the Ebola break. And also now we are facing how to establish, to have health personnel qualified in remote areas. They tell you, okay, if we go there, we have housing challenges, we cannot have continuous training, we are totally disconnected with university and everything. We say, okay, we cannot solve everything, but we can make this connection. Sitting in these remote areas, you can see your professor, you know. He talk with you, he give some guidance, and it can help to overcome some challenge.
So by this, you can manage to not only train the physicians in rural areas, but also keep them there on location, not moving away to more popularized cities.
And other thing very important is data collection, because we need data to make decision early sometime. Even now we face health public emergencies are taking, if I can say like that, we lead now. And things. So we have to also readjust ourselves to face that.
Yeah, so you gave really two great keywords, which I would like to pass on to Natalia and Titus. Starting with Natalia, mobile networks are often the essential communication infrastructures in the global south. How does the GSMA and its members engage in building better health infrastructures where countries like Mali also can benefit from?
I think we just recently looked at the difference in access to doctors, nurses between developing markets and in Africa in particular. We talking about one doctor per 5,000 people.
One doctor per 5,000. How can this person handle that?
So imagine the availability or lack of availability of like very basic services we're talking about. So there is a lot of hype, and there's been a lot of hype for the last 10 years about that cell phones are going to solve all these problems. Well, it's not necessarily that easy, and there were quite good hints towards sustainability of such solutions or scale or connection to public healthcare system, which we probably would talk about it later on the panel. But what we need to know is that there is opportunity there in terms of availability of infrastructure that we can leverage on. It's not going to offset all the gaps in the healthcare system, but we can try to some extent cover at least part of it in terms of efficiency, accessibility, quality, and cost.
How can you actually do this?
So we're talking about, so at the moment, there are 4.8 unique mobile subscribers in the world. This 4.8 billion unique subscribers of mobile phones in the world. And so we're pretty much talking about there is at least one phone per family in most cases, per household. So there is connectivity. By 2020, it will be even more. That there is a lack of business case to extend connectivity in very rural areas. We're talking about nomadic population, and this is where it becomes really tough. But covering cities, urban areas, villages is possible. Now the problem there is not creating the solutions which necessarily will be available to the end users, but creating the digital solutions for the hospitals, healthcare workers, as well as the end users. And this hasn't been necessarily done so far in a scalable way in most of the developing markets.
So could you say it's like technology development cycles are exponentially growing faster than the infrastructure that is actually needed to implement them?
No, I disagree with that. We're talking about digitization of healthcare sector in developed markets, which started in around 1960s, and right now it's 2017, and most of the hospitals, community health worker systems run on paper, or the community health worker comes without any paper at all. And how can you talk about early monitoring or surveillance of any potential problems or outbreaks, because you have no idea what's going on. So we actually lagging behind. And there is lots of hype about AI and predictive analytics, but you can't deploy that if you don't have digital records in the first place. So I would say that we need to catch up first in terms of basic infrastructure accessibility in developing markets before we can talk about image recognition, real-time diagnostic, and
got it. So we need the human factor first. Titus, please excuse, I have to move to Heidi first, because to leverage digital health, digital skills are required. Would you like to pick this call? No? Okay. And can you describe the skills that are needed? As Natalia pointed out, you need digital workers in the field, more or less. What kind of skills are required by people who are more or less the key persons?
Sure. I don't know if this
IT, can you help us? Okay, I think it has to be turned into airplane mode. Okay.
Okay. In terms of the skills needed, I think one thing I hear consistent. Can everyone hear? I think one thing I hear consistently is, the workload that's put on physicians in terms of data collection. That there's a lot of time needed to do that, to capture data and move from paper systems to digital systems. And I think training data collectors in how to collect data well as a separate sort of workforce, and understanding the importance of that role of data collection to feed into a larger system is one key sort of human resource capacity. I think another skill and another challenge is one of coordination. We are all often working in silos and building things that are parallel to each other instead of working in better coordination and building upon tools that are already doing maybe a portion of the work. So coordinating that capacity building across the spectrum in a country to make sure that we're working more collectively is really important. And that capacity was anything from ensuring that e-health strategies that exist in a country are actionable. So, training, making sure that there is training to develop and roll out different strategies is one key area. Having universities offer ICT and health informatics courses to train an upcoming career group of professionals who can then be local experts in country. I think that's a real lack in a lot of places, or in countries that do have a health informatics specialty within the university, making sure that there are jobs for them to move into to continue that building those skills.
Understood. Michael, Heidi spoke of digital strategies that are required also to more or less develop skills. And what kind of role does the GIZ play for the work and its partners regarding digital health?
Well, for us, digital health is becoming increasingly important and gaining momentum in our collaboration and our entire portfolio. There are more and more digital health interventions and applications available.
Could you define digital health? How would you phrase it? Because it sounds like a buzzword.
You're asking the only one on the panel who's not a digital expert.
Nadi can jump in.
Sure. I would define digital health as the use of information and communication technology for health system strengthening, just as a basic definition or simplistic definition, but there's definitely more packed into that.
Can you put this into 140 words on Twitter? What's digital health in short, if you explain it to a child?
If I would explain it to a child, it's how can we use technology, even the phone that you're using, the computers that you see, and then within healthcare or within health systems.
Okay, thank you so much. So the role of the GIZ in this setup.
Yeah, well, I found this actually very, very interesting to see also now from the beginning of this session, what resonates with a person that comes from the health sector and all the jargon and language that is being used by the IT people, And I immediately could connect to what Dr. Salif was saying when he was talking about the SDGs now and talking about...
What's an SDG?
It's a Sustainable Development Goal. This is something the United Nations where all countries subscribe to. It used to be the Millennium Development Goals, and now we have the Sustainable Development Goals. And UHC is one of the central goals in the health sector at the sort of like intersection to social protection. Now, this is something...
See how language is important?
Yes,
right?
Yes, I think it's very important. So coming now to the role of digital health in our work, there is GIZ as the implementing agency for the German governance. We experience there on a couple of levels some change. On one hand, we see a proliferation of this e-health, and there are more and more requests from partner countries coming. Mm-hmm. So our portfolio has actually is accommodating e-health in about 17 projects. 17 projects, okay. Health projects we are running across the globe. And the investment in the digital infrastructures is about 30 million at the moment. You know? But then there's also other issues, you know, the shift that Dr. Salif was mentioning from MDGs to SDGs is also affecting our wealth. The MDGs, the Millennium Development Goals, when you're the ones who remember these times, when we had more supply side and disease-oriented focus, that is now changing, and with the SDGs, where universal health coverage, I can also define that for you if you like. That means that
I'm like
everyone,
a huge Twitter audience. Yes, please.
That everyone has access to quality health, the needed quality health services, without experiencing financial hardship. So this is closely linked to leaving no one behind and all. So the SDG and the universal health coverage, that is now a shift away from the supply side and from the disease-oriented thinking, also including demand-side interventions. And demand-side interventions, one of the examples would be what we do in Nepal, the open HIMIS. So this would be an open health insurance management information system that we are developing together and implementing with the Nepali partners and also in Tanzania. That is basically something for an IT solution for a health insurance that they're currently implementing in the country. And this enables that organizations to purchase basically or to improve the purchasing function on behalf of the members they are enrolling. So that's so. And the other one, we also have more room now for health systems interventions, which were before the funding more going to vertical kind of programs. Now we have more resources available to do system strengthening. And IT is, according to WHO, in one of the building blocks. Mm-hmm. So in future, we have not only the demand now, but we will also maybe see more investments in this.
So you come from an eagle-eye perspective, you look at the health systems, you look at, let's say, hotspots where you can jump in and provide not only knowledge but also funding. And how far have you also now focused on the sustainability that Salif mentioned? Because he pointed it out like, okay, there's a project, money's running out, oops, project is kind of dead. In health, that means killing people. So how are you now shifting to sustainability? What are the tools there to drive that change?
Yeah, well, this depends a lot on the level and the economic income of a country. You know, the health system in a country doesn't operate in isolation. It depends on how the country is raising taxes, how they are mobilizing domestic resources for health. You cannot reach a universal health coverage without using the domestic resources. The dependency on donor funding, that cannot be the future of UHC. Another important aspect talking about UHC is that this is now an agenda in the
universal health
universal health coverage. This is now an agenda which is valid for all countries. So it's not like a north-south thing where developed countries are doing something for the developing nations. This is some agenda where we work together as interpowers and have rather a joint learning, because the challenges we face also even in Germany and in the developed world, is to sustain universal health coverage. And you can see in some countries it's a big problem to do that, you know, if you look across the Atlantic, for example.
Salif, you would like to add something?
Okay, thank you. I will want to jump again on this the point on the sustainability, just to push again, because as you say, it depends on country development in the economic side, but also it depends on another thing. This is the call I'm making now. We have to change the way in which we are working on the past. Because what I'm trying to put on the table is, even the country is poor, this maybe is not the unique problem. What I want to say, if we want to help, we came with the project, we have to rethink how we bring projects. Because in the past we say, okay, we have this grant, we just come and drive everything, and if the grant is finished, the country have to run himself. What I'm trying to say is, since the beginning of the project, we have to use also the money to help the country to go for the exit, and because this is the way for sustainability. In the MDGs, we was not working in this way. We have to take the opportunity of this commitment on SDGs, because the name is sustainability. This is the name. So we have to be sustainable on everything we are doing.
Maybe Titus can help here, because as a working cardiologist and running this Institute for Computer-Assisted Imaging, data is the new oil, it's been said so far. And to create sustainable systems, from your perspective, what needs to be done with the data setup from the very beginning? Could you give us a bit more information on that?
Well, thank you for giving me this very difficult question.
Of course.
I mean, this is probably one of the core problems with any international aid. How can you make projects sustainable?
Yeah.
And I think in health, very little is sustainable, because you have a permanent need for resources. So the question is rather, is the country willing to finance and or provide a co-financing of these infrastructures that has been established by funding agencies previously? And if you find out at the beginning of the project that there's no willingness, then you better don't do it. If you find out at the beginning of a project that there is a willingness, then you at least can look for an exit strategy when the funding money is it's endless, obviously, and it's not existing anymore. So I think it's a question of mind setting also, and there's no global answer to this global question.
So do I get it right? If the country itself doesn't jump in financially, the project sounds like being doomed when the money runs out.
I mean, digital health is obviously very, very colorful, and it's there are small projects which you can target and which you can find solutions with very little money. You just need a player on the ground.
What would be an example for a small project?
Let's take a project, actually I know from Mali, that has been funded by the Dutch government about 5 years ago. It was about teleradiology, and I think with the department in the capital city of telemedicine, they showed even that there was an improvement of medical outcome of image reading. So there have been obviously very engaged people doing this project, and I think in part, correct me if I'm wrong, it's still living, this project, even if the Dutch are not supporting it with fresh resources anymore. At least the mind setting seems to be still there. And that could be an example. So you have 2 or 3 doctors who want to communicate with each other, and that can be enough.
And also the data could be used for medical training for physicians in rural areas.
Well,
the image reading?
Training is a difficult topic. You can, of course, say, well, I train somebody with e-health, but if you do not have the contents for training, then you are lost. So training is probably one of the hardest thing actually to do in global health and digital health, using these technologies, because the technology is easy, but the contents, the curriculum, what do you want to train, that can be very hard. But to not mix the questions, so the small project with the right people can do a lot already on a very local scale.
Yeah,
definitely.
Natalia, you wanted to add something?
So we recently also have done an overview of all sorts of digital healthcare solutions which exist out there, and we roughly segment them by the solutions for the end patient, solutions for healthcare workers, solutions for the hospital, and larger solutions for the health system. And roughly, like in the introduction, I might have skipped that, but what we usually do, we work with the commercial sector to find and prove business models, which could have been very unlikely a few years ago, but there is big demand, and means there is technology, and it means there is potential for impact. Can we look at how it can be sustainable? And when it comes to digital healthcare, if you go through this categorization, if you talk about end-patient solution, where a commercial company provides behavior change communication to the end user, receive text message saying, don't forget to eat carrots. And there might be a solution for healthcare workers that supports them with diagnostic. So they, if they haven't done lots of training, they can still look for the right symptoms and record the data and maybe research this later if they can't give an answer on the spot. And then for the hospitals, that's of course the digital systems, the image recognition, and visibility of the stock, and many other things. And when you talk about just the solutions for the end users, and that's what the digital healthcare was mostly focusing on in the last few years in Africa and Asia.
Who's the end user?
Yeah, but you bypass the whole system, which is not functioning. So you provide a solution to the user, and the advice that you give them, go and talk to the doctor at least 3 times before you deliver.
So you try to fix broken systems.
Yeah, they actually, you can tell them that, but then there is no way to follow up if they actually received an appointment with the doctor has seen them, if all the data, let's say community health worker from an NGO might have on that user actually has been passed to the doctor. So when we talk about systems like that, for the end user messaging, there is almost no business model. There is a little bit of loyalty. If you manage to reach 500,000 users, you might see some loyalty to the mobile network. And there is some willingness to pay and some willingness from big organizations like maybe Unilever to push the advertisement of their soap to these people. You might have start cross-subsidizing this behavior change communication. When it comes to community health workers, the systems, if they're designed for NGO health workers, they can optimize the NGO costs. So they can be sustainable in a way for this NGO, but they are not necessarily linking you to the healthcare system, which is an obvious gap. And if you want to create solutions for hospitals, there's only one payer. And that means that we need to have a government on board early on when we design such pilots. And the government should say, these are the specific KPIs of this project I would like to see as a result of implementing this technology. And if it's met after the pilot, I will come in and I'll start financing this. And we've looked at the potential amount of money that can be released from the government funding. And if they just spend 0.5% of the current health budgets in developing countries on digital strategies, there will be a release of $25 billion in the next 5 years for health tech companies.
0.5%.
0.5% of existing health budgets.
This is a big number. What is an example for a house budget? How big is the house budget?
I think we can ask a person that we have on the panel. Can we get an indication of the health budget and how it's been spent and roughly the size for a country?
No, it's not for a budget side. I just want to make a point because my friend, excuse me,
Michael,
was saying now that, no, it's my neighbor. He was saying that to design the curriculum can be very difficult with digital solution if you want to establish. What I want to say here is, we can, if the infrastructure is in place, we have many opportunities to use with the same infrastructure. So this can be very cost effective. And I'm not, let's make also things simple. Because sometimes we are very afraid and we worry with complicated and very sophisticated things. You know, to change indicators, we have some activities which have a very great impact. It's a very simple things. So this training is not very academic trainings with complicated curriculum. No.
So it's like the quick wins from the ground up.
We have some information, some behavior change with health personnel, and some attitude to give to health workers, and this can make a big difference.
And this big difference, I would like to invite Nadi to give us an example from her experience regarding projects, as also Natalia gave some examples of what can be done, text messages sent to the end user. What has been your experience so far with digital health projects, and how have they become successful or not successful?
Sure, I think... Hello, okay. I think that we sometimes have to take a step back, and so a lot of the time with the work that I do, especially on the advising side, is, you have to start with some questions. What is the vision? Does it make sense, for technology to be integrated into this? Because sometimes it's not yet ready. The other thing is technology is a tool. And it has to sit within, an enabling environment, an ecosystem, which I think that's kind of what everyone on the other side is saying, right? So sometimes it's not quite yet ready, but maybe we can keep an eye on it, right? But then if, there might be an opportunity for technology to be implemented, you have to also ask what already exists. Why are we duplicating things? Why are we also keeping ourselves within maybe particular disease silos? Maybe we can expand on something that's already existing. And then after you understand that, you can also move then to who also needs to have a seat at the table as we're having some of these discussions, as we're thinking about the design, as we're thinking about the implementation. And I think, the two key stakeholders that often get missed, but there's attention now, there's growing attention to this. It's, I guess, what we've been calling the end users, whether that's the healthcare provider or if you're directly targeting the clients of the health system, the clients, also the beneficiaries, which would be, the people. And then the government is the second stakeholder that definitely needs to be involved or at least kept abreast of a lot of these discussions that happen, especially because it's very important, and we're seeing this now as a trend, for initiatives, digital health initiatives that are being implemented, if they haven't engaged with government or if they're also not paying attention to whatever the government health strategy is, and then also if that government has a digital health strategy, what the key principles and priorities are, then oftentimes these projects are so disjointed or disconnected from what's taking place or what could also succeed. So I think I just wanted us to also have that perspective that we really do need to ask some of those key questions and think through that as we're having these ideas. Not to say we shouldn't have these ideas, not to say that we shouldn't be using technology or be excited about it. We should, but we really have to think critically about it. The other thing I would say, and I think Natalia was pointing to this, is also when you're developing a project, it's very important to define key success metrics at the beginning, and this is also what Dr. Salif was also mentioning, from the very beginning, how do you also have considerations for the exit strategy? And so I think, there's a lot that needs to happen at the front end, and it's a lot of heavy lifting. But if you get it right, and if you really are also open to maybe not succeeding initially, but also having an iterative process. It's not just a one thing and then we go. No, it takes like a lot of back and forth. It takes, different changes that must happen over time. But I think it's really important to make sure that there's that roadmap or that theory of change that you've established at the very beginning as well. And that's very helpful. But I think
No, I'm good. Titus just mentioned health is like a process. The whole work in healthcare is process-oriented work. And I'm curious, what has been one of your best practice examples? I would like to really get a hands-on example. How did you manage to improve what in your citiesRISE communities?
Yeah, so citiesRISE is still relatively new, but one of the initiatives that we have is there are a couple of different organizations who have these digital technology implementations that they had already done, but where they came to us, or more so myself as a technology advisor, is, we wanted this, we ran forward with it, but now we're stuck. And we realized that maybe we didn't know what to do.
So who is it who comes to your project? Who knocks at the door?
Yeah, so it's different mental health organizations, typically grassroots organizations who come to us. But I think, to make a long story short, it's oftentimes kind of cycling back to those key questions that I'd asked. We go through that, and then we also work to see, since they've already been implementing, how we can improve or strengthen their implementations. And so we're going through some of those activities now.
Norman would like to add something.
Well, I kind of want to ask the panel kind of a general question and responding to that. A couple of years ago, if we would have sitting here, I think many people were thinking kind of, what the heck are they discussing? Digital health, it was like some people, but not everybody. Today, kind of digital health is becoming normal, and then we see kind of the discussion starts with the challenges. How can we improve? How we can become better? And there's a particular global south perspective also in this discussion. There's drones in Rwanda used to transport blood packs. There are electronic medical records basically in almost all countries in Africa as a nationwide system, something we discussed in Germany for years, and it's not implemented, but you actually would see this in this global south.
Oh, you mean our health record?
Yes, exactly. There is community health workers kind of using mobile health solutions and expanding the geographies of health in ways we couldn't imagine before. So there is a lot of potential, and this is also why there's, this huge discussion on it. But I guess all what you were kind of hinting on is, it's not kind of doing that what we expected to do it. We heard about challenges of funding, we heard about the challenges in training. But maybe to all of you, kind of where would you see, and this is going a bit away from the challenges, where would you see the biggest impact today in these kind of technologies? If you would need to recommend to somebody, like, do this next, what is it? I don't know who can answer that.
Well, everybody is invited who likes to jump in.
Mine maybe isn't so much do this next, but it's more of, this technology has offered up the ability for us to have a lot of information or a lot of data at our fingertips. And so it's more of how can we use the data better, or how can we also think about, maybe having that data presented in a way that it can then be used to make decisions and more timely decisions. And I think there's some examples of initiatives that are doing just that, or trying to get that right. And I think that that's very exciting, as we move forward into the future.
But what is the role of the government here? How can they actually support digital health projects? We've now kind of named all the stakeholders. So what's the call to action to the government, Heidi?
So I think there's a role for government to implement policies and have a structure there. Policies, but also it's multi-layered. I wanted to point out that right now, 2 weeks ago, there's an ongoing development of an East African digital health roadmap. And I think this is really important. So there's collective action, not just by the countries of the EAC, but regionally, to look at issues of cross-border migration and how that impacts health, and how that is impacted and impacts health systems and data collection and facilities-based care, all of that. K4Health, along with VitalWave and USAID and others, brought together stakeholders in the EAC. The East African Regional Health Commission is driving this agenda. But having governments get on board together and agree to move forward collectively and to look across borders.
Sounds a bit like Star Trek.
It is, right? But to just be at the table together and really figuring out what the challenges are and how they can reasonably move something forward, to have a collective roadmap for digital health, I think is amazing leadership.
And Michaela, and how far can we or you from the GIZ measure outcomes from health projects, which could be important to governments?
Well, I think we need to be honest here as well. At the moment,
I hope so.
we can't manage, we can't measure any success, or we don't have really hard evidence at the moment that we have successful IT interventions that are at impact level. We're talking mainly about process. We are talking about how many people are being reached, or how many people are enrolled in or membership of a certain platform, and all that.
When do you speak of an impact level? What needs to be
Impact
fulfilled?
level means the direct effect to a target group, to the people itself. Then impact would be, for example, what we could measure if you distribute bed nets and you see a reduction of malaria, or you treat someone with antiretroviral treatment and they become, at least for some time, virus-free in the AIDS area. So all these investments we had in health and the attribution to impact, anyone who invests in this, any donor who invests in this, any government also in the developing countries, they need to show success, and they need to show this. Once we move towards health systems development, it becomes again very difficult, and IT is always something that is supporting basically under other interventions, so it's sort of like mingled in, integrated in there, so it's very difficult to do this. But that doesn't mean that we give up on it, because I think it's still the right thing to do, to invest in something that makes life easier or more efficient, because the potential is definitely there, and by common sense I think we see it's there. Emails and those things, they helped us to improve, instead of sending posted letters to other people, it makes it much faster, and of course it brings much more work to your table anyway. So, but we have to see it's the right thing to do, and I hope if we engage more in collecting evidence, maybe at some stage we can come up with some factor to say, like, if you have an IT solution docked onto this health intervention, that it can increase the efficiency maybe by 1.5 or 1.7. That would be something. Right. But we need more data on that, and we need to jointly collect that.
That's kind of tricky. I mean, in the past, Heidi, we've seen so many digital health projects that did not meet expectations, and we speak of pilot Titus, which is also, I think, a German phenomenon. That means too many pilot projects. You start something, you kick it off, and as Salif said, money runs out, project kind of sands out. How can we ensure that we learn from the mistakes made and that we really design for scale and sustainability?
I don't think pilotitis is a German phenomenon at all.
Also, it's worldwide.
Unfortunately, I think everyone in this room is probably familiar with pilotitis.
But we have an example for electronic health records. It's only 10 years old.
Sure. I think it's hard. There are a few, if I can put this out there, I think one frustrating factor or driving factor of pilotitis are donor work plans and deadlines that compete, very frankly. USAID, DFID, GIZ, Gates Foundation, all on different timelines, all with reporting at different times, and you start a project and there's a push by all of us to get something done quickly and have immediate results. And we may not all take the time that's really needed to look at who the end user is, as Nadia was saying, who the end user is, culturally and given the infrastructure, what's really the best technology to reach that end user, and functionally, what would be the best technology to reach that end user. There are digital health landscapes that exist for...
Who did them?
So Health Enabled, Nadi's previous organization, healthenabled.org, you can go there, and there are digital health landscapes for about a dozen countries now, mostly East and Southern Africa.
Yeah.
This was an intense sort of research collective to look at what exists in each of these countries, what structures are in place, policies, current projects, the current as of, let's say, in the past year. So having these quick snapshots available, they're not available in every country. So finding out what projects are happening, you go to the Ministry of Health, you talk to people, but it's really time-consuming. And it
means like 6 months, a year, or?
Well, it changes so quickly, right? I mean, there's, when there's investment in a country, a lot of projects start up. And so I think having more digital health landscapes so that we can all sort of get up to speed quickly and be able to build upon each other's work in a more informed way is key to not having so many pilots and really at a national level looking at what works, talking really candidly about what didn't work, and then trying to move that forward. And facilitating some of that are the principles for digital development. I don't know if all of you are familiar with this. Digitalprinciples.org will give you that. There are 9 principles.
Digitalprinciples.org. Yeah. Please tweet it and use our Twitter hashtag.
So the Digital Impact Alliance, DIAL, is leading this work. There are dozens and dozens of organizations that have now signed on to realize these principles. So I'm just going to read them off really quickly because I think it might be useful. So the 9 principles are to design with the user, understand existing ecosystem.
Design with the user, does it mean the person who is using the service or providing the service?
Both. I think it's like we said, really making sure you understand your audience and using appropriate technologies,
so
right?
Sometimes
is
design for
pilots,
the user.
We start and we realize we're kind of missing the mark, right? So really taking the time at the front end to design for your user. As Dr. Samake said, designing for scale, so from the outset, knowing where you're going in 5 years and how that's being handed off and what.
Design for scale means like looking at also maybe the disease indication or the end user. What is covered in this 5 years? What do you mean like design for scale?
So I think it looks at financing of the project and training that would need to happen so that a project can be properly handed off in 2 or 5 years' time. And lining those things up along the way so we're not stuck at the end of that project. Right? Being data-driven, mobile-friendly, mobile-first, using open data, open platforms that are not siloed, that are built so we can build upon them, reusing and improving. So, again, building upon each other's work, addressing privacy and security, and being collaborative. And I believe it's DFID is now incorporating these 9 principles into their contracts, if I'm correct. So having these principles be key to your work tied to deliverables, right? If it's not collaborative, if it's not open source, if it's within contracts, that's a way to actually help support, a non-pilot, scalable work. So one thing I would sort of recommend we all look at.
That leads me to Titus again, because there's a continued discussion on open source versus proprietary software solutions. What do you recommend a policymaker? What should actually be user? What should be the questions to be asked to make a decision?
So should the project be sustainable or should it be innovative? So it's a little bit 2 poles, 2 extremes, I think. And the same relates also to the question if I want to take an open source solution or if I want to put some emphasis on innovation and maybe go with a new idea into the race.
How do you define innovation then?
Well, we are sitting here together and maybe doing some brainstorming and somebody of us has having a good idea and then we are continuing to bring this into technology and then we test it. It will be another pilot, of course, but without these kind of things, we will not make things different to what we used to do in the past centuries.
So we have to test, more or less. We have to find out if we really add value.
Yes, of course. I mean, it's always a balance. I mean, you can be too innovative or you can be too conservative and just say, okay, everything must be really sustainable and we go with the existing standards. Both is right. It's not a yes or no. And the same probably is true with the open source things. They are free, available, but you need, of course, put money, a lot of money sometimes, to implement them and to optimize them for the specific use case. So you have to think about the project and then either decide, okay, I want to go and control the technology myself, then open source might be the right thing because I want to do it for 10 years. Or you want to target a very specific problem, then a commercial solution where you pay maybe 5,000 euros for a license might be the right thing.
Okay, so there is no yes or no, it's depending.
Unfortunately not, no.
As the challenge, but maybe Nadi, can you give us more insight before we open up the panel to the audience? In how far can a project run on its own or require extra funding? What are the pillars in a best practice example? I'm still knocking on your door. Give us an example, please.
It depends.
Oh!
No, I think because it really does. It really does depend on, you know, the goals and everything. I think we've already harped and touched on some of these other things about, like, you know, that, you know, programs, maybe they're grant-based and they have like this short-term lifespan as well. And I think that, you know, like the financing bit, there's some hard decisions that need to be made, right? And so I keep going back to kind of like, you know, defining success and, you know, developing a roadmap and theory of change, because there will be some hard decisions along the way that you'll have to make, especially from the financial standpoint.
And who gives you a backbone here? Who actually supports you in making this decision? And also who's depending on you?
How do you mean?
I mean, you have to make a decision in a project, and the outcome is affecting people's health.
Yeah, and I think that also comes back to, you know, the stakeholders. Sometimes you can also bring them in to, you know, be involved in some of that decision-making process of saying, you know, here's what we have and what can we do, you know, as we're thinking about, you know, the financial limitations and so forth.
Yeah.
So I know I'm not giving you an explicit example, but I think
let's talk about mental health.
So I think that those are some of the tough decisions, but at least in the mental health space, a lot of the projects have either been like research focused, so like short-term grant-based research type of funding. If it's you know, maybe NGOs that are implementing some technology within their programs, they're also primarily grant-based. There's not really, you know, necessarily a business model that I've seen outside of that, but there are some innovators in this space who are trying to develop some proprietary software that, you know, maybe it predicts different types of like mental health issues or anticipates for early decision and early action, and where they're coming in is, you know, being able to sell that software then to various types of organizations who would then use it. But that's from like the technology vendor standpoint. So it's a tough question, tough decision. It depends on like what your organization is doing and why they're using technology and what they're using technology for, or if they are the technology provider. So it's like there are a lot of different actors involved as well.
And you gave a good hint that even the actors have to know the agenda of the government. Michael, sorry.
I just wanted to quickly respond that it sounded to me a bit like the impression is in the room that we are making decisions on what we're going to do on IT and all this. I think when we work together with countries, we have to make clear that really the partners in the country are in charge. And mainly, at least for GIZ, who's implementing on behalf of the German government, they're working together with other governments then. So there's, of course, some difficulties, you know, then the literacy that is there and the understanding in some of the public institutions like the Ministry of Health and all that, you know, it's very difficult then sometimes to find people to interact with and to explain to them what it is. So from our point, on one hand, it's very important to support them to make informed decision then about this. Another issue about the pilotitis I wanted to talk about is one remedy for this is if we support our partners in the countries in their strategy process. Every country has their whatever 5-year cycle on national health sector strategic plans, which in some cases are maybe reduced to a Ministry of Health plan and not really a national plan. But the idea is that it is a national plan, and that is a plan that includes all the different system building blocks. IT is one of those building blocks, and I'm not sure how in-depth this planning is in many of the countries, and if there are missed opportunities for us to meet at that platform, because that can solve maybe some of the issues of the funding that is there, that it's not only externally driven, that this is sort of like where the country itself is involved in the decision-making, how resources are being moved from one end to another in this.
That leads me to the last question before I open discussion round up to the audience, and I would like to ask Norman as the co-host, because Heidi brought something up, and Michael as well. GIZ can support the governments and the countries, and the stakeholders, or maybe the innovators, are also in the country. And I remember that there has been a hackathon last year in Africa, and you met a lot of entrepreneurs. So what has been your experience working with these local innovators?
Sorry, I guess that's also a tough question in the sense that we, and the challenges we heard, we're always discussing about public health systems in the Global South, which are extremely difficult to deal with innovation in a sense. So we would have kind of entrepreneurs, startups developing actually great ideas, queuing systems, telemedical kind of applications, diagnostic devices, using
nursing
AI.
Tools as well.
Exactly.
Yeah.
Now you go to the Ministry of Health in Mali and saying, I have this great idea. And the ministry even says, yes, that is a great idea, but like, how can we implement it? This is actually the question the ministry cannot answer kind of right away. It's a matter of funding, it's a matter of kind of institution building. Very often these technologies, it's not about the technology, it's actually kind of building the institutions around them. So it's not the logic of a private market that kind of finds the best idea and implements it. It's a very different logic, and I think it's this was our experience with the hackathon in Kenya. It is kind of easy to find good ideas.
Hackathon means a lot of people come together for 48 hours and use computer technology to work on healthcare ideas that have been developed there?
Exactly. Okay. And this was a 3-month program where they kind of developed a prototype and then presented this prototype to our Chancellor Merkel here in Germany. So again, great ideas, but the question is what to do with them, how to implement them, how to scale them up is kind of the harder one instead of finding them.
Okay. Last remark from Natalia, and then we finally open up the panel to you.
Thank you. I just want to answer the previous question about what needs to be done, and I think we need to transition to understanding the government as the client in this situation. Otherwise, we're creating digital tools for NGOs to offset the problem of the healthcare system. But the government as a client, this should be the new paradigm, and we need to look at other countries that managed to do it. We have fantastic examples from South Africa and Indonesia, where government starts upgrading their systems, and you can find different arrangements with commercial players, and there are tech players that can package the solutions for supply chain visibility, for community health workers, for the end users, for hospitals. But we need to work on best practice there and procurement and digital strategies.
Okay, now it's time for you. Oh my God, questions. Katarzyna is passing the microphone around. I will switch. I keep my headset. Okay, so the lady right in the middle. And Katarzyna is bringing the microphone. It would be nice if you first introduced yourself to us so that we also know who you are. And here you can see real teamwork in the audience, passing the mic. We've got now 15 minutes for Q&A, and so feel free to ask everyone here on stage.
Gina Merritt, I'm the president-elect of the Union for International Cancer Control and the former director of the King Hussein Cancer Foundation in Jordan. I wanted to actually confirm what Dr. Michael from GIZ said. You need a system to start off with something. You need a comprehensive strategy at the government level. And what Nadia or Nadi said, digital health, you digitalize a health system in place. But when there is not a health system in place, you cannot digitalize a void or a messy system for that matter. So all these effects, you have different, all kinds of, goodwill intentions from so many countries. If they don't slot into a well-designed strategic plan to start off with, it really becomes just an ad hoc approach. And I really want to mention here something that UICC is doing now, which I totally believe in. And the reason I believe in, because I come from the developing world, and I've seen what happens in our countries. And it's such a similar story elsewhere. The UICC now has launched a very important logical initiative, really a first of its kind, where it's actually starts with the plan. It's called the City Cancer Challenge 2025. We now go to a country, let's say we take Asunción or Cali in Colombia, and first of all, we tell the government, we say, look, are you first willing to invest in cancer? Because that's the world I come from. Are you willing to invest in cancer? Because if there's no political will, we all know nothing will happen. 2, are you willing to work multi-sectorially? Sit on a task force that has everybody on the table. And you know how hard that is with all the egos and the agendas in place. And if they accept that, then we say, okay, we're coming in. We have over 1,000 wealth of members from all the cancer community in the world. We've got the World Economic Forum, WHO, UN partners, etc. But we will help you, and that's exactly what Dr. Michael said. We will help you strategize. Most countries in the developing world, they don't have the capacity, either at the government or the health ministry level, to actually strategize. Most people are just doing tasks. So they will work with them on a plan.
So strategy first, then you can
of course,
execute
if you
the
want to
tasks.
build a house, do you start
But
calling
strategy
suppliers?
needs a goal. What kind of goal is there? The goal has
this
to be
is it.
unifying as well.
First of all, they will help them do a self-assessment plan.
Okay.
And they will work with them for 3 years. They will handhold them. They will bring in the technical expertise and make sure that everybody sits on the table, from patient groups, from NGOs, from international business, and so on, and they will set their priorities. Digital tools are fantastic, but certain countries are not ready there yet. It sounds lovely to have everything
But this is why we have this call to action, and I heartily invite you to join the call to action and participate in this call to action that is going to be published on the World Health Summit website.
Yeah.
And I really thank you that you more or less approve what Micha said here on stage. And if you'd like to discuss with us later, it's also great.
Okay.
But please, could you pass on the mic to someone else?
Sure.
Right behind you.
You didn't give much chance.
Thank you so much. Thank you.
Hi. I'm Maya. I'm a PhD student at the University of Göttingen in the field of development economics. And my question is actually very similar to what the lady before me has said. So I'm wondering still about the premise and the concept of telemedicine, really, and I think it also touches on other aspects of digital health. So my understanding is that especially telemedicine is also to scale up the access to healthcare, yes, but the problem is still, as has also been said, that there is just so little capacity. There's so few doctors and healthcare workers in general. So how can we even use telemedicine as a solution for this problem? Like, doesn't it just put more work onto the existing healthcare force? Is it not more important to first get the healthcare force up there, and then if we do that, can we directly implement that in the remote areas rather than implementing it in, let's say, the urban areas and then working with telemedicine to get the scaling up going?
That's a really good question, and I'm so happy to have a real physician, a practicing cardiologist here. But collect the questions? Another round? Can we first answer this question? That would be great, and then we collect questions. Okay.
Okay,
Please.
I'll try to make it very fast. And just fusing the comments from Jordan with a question from Göttingen. So cancer and telemedicine, this is a thing which really comes together. And this is, of course, I agree with you, without a program and an idea nationwide, it doesn't make sense to make it nationwide. But sometimes it's just a hospital. I have been partially involved in Göttingen when the tumor board sessions have been established there. So it's a collection of physicians taking care for a patient with cancer. They're coming from different disciplines, pathology, neurology, radiology, and they want to share the information. And the tool currently is telemedicine. Mm-hmm. So you do not need a nationwide program for doing that. You need a hospital, a group of physicians who is taking care and who wants to do that. And so the question can be sometimes very simple, and sometimes it can be, like you said, extremely difficult, and it will take years for finding a solution. It really depends on what you're looking at. A small group of people who want to use telemedicine, that's fine, that's fast, that's easy, or a national program where you really want to collect systematically data and have a concept behind it. Can be the same, can be part, but it can be also isolated, in my opinion.
Mm-hmm. I have to look at the time, so Norman made a good suggestion. We collect questions now and then discuss them later with respect to the next people who join this room, right? So there was a question, right?
I'm here, I have the mic.
Oh, you have the mic already. I can throw it to you.
I have the mic.
Hello.
Thank you.
You got the power.
Yeah, I'm Dr. Salif from Ghana. I'm the Director General of Ghana Health Service. You see, somebody said it rightly. If you leave digital health to development partners, it will not be sustainable. It should be owned by the government. And if the ownership is strong, as it was in Ghana, we were called one day by the Vice President, and he told us, Minister of Health, Ghana Health Service, we want your health system to be digitalized. So go and work on it and come out. So we have the laws, we have the strategic plan, we have the training of health information officers. We have now mobile health from the community level. We have community health planning system, CHIPS, the lowest level. We have teleconsultation. We have now telemedicine. We have now done all the budgeting and everything for telemedicine. We are looking at digitalizing our health beyond aid. Mm-hmm. If you always depend on aid, nothing will work in health. Because health, as I understand at cabinet, is the least thing discussed about, because it doesn't bring money. So everybody here should think about doing it on their own, and then leveraging health systems through digitalization. It makes the work easier, it makes the workers happy, it also gives support to the lower level workers, so that, and then the patients or the community who is also receiving the health also become happy, mm-hmm. because they have somewhere they can look up to. If there's a tele-radiology, tele-diagnosis, the pregnant woman doesn't have to move from the village to the next center to go and do a lab test and come back in 3 days or 4 days. The person sits down there within 1 hour or 30 minutes. The result is sent by through mobile phone. We also share ideas. We are using adolescent health. They are on apps where they can discuss menstruation, how to keep yourself healthy and all these things, about HIV, AIDS and everything. And in Ghana, I'm happy to say, we have taken advantage of community health worker approach, which AU have said. So we have deployed 20,000 community health workers, and we have trained them and given them mobile phones, where they are using to collect data, first-time data. They are also using it to make sure that they can also educate the people on appointments, people who are pregnant, who are home, who are not going to hospital. And these are the things that you are doing.
With respect to the audience, I would like to collect more questions. Thank you so much for making this statement. We have a question right in the corner. If the technician, please, can help us fueling up the mic.
It's
here.
You go. Thank you. My name is Ricardo. I'm a member of Parliament from Portugal and also the head of public health at the Católica University in Lisbon. I know we're tight on time, so I'll go straight to the point. Picking up on what was said by Nadi, that digital health can help strengthen health systems. I would actually say that we need to go even beyond that, because the truth is our health systems are sick. We are focused on an industrialized model, and we have to use digital health actually to put us in the direction of a community outcomes-based system focusing on making people healthier. Because I would disagree with the argument the governments are our final clients. The patients, the citizens are our final clients, and the governments are there to serve as elected officials, and as an elected official I can say this. And so I actually believe, and I'm trying to bring on an additional angle here, that we can actually use digital health to push governments, to push policy makers in the right direction. And as health specialists, we have this tremendous opportunity to have this ground-up approach. And at 12:30, next door, Oceania Room, you're all welcome. We're going to present a tool on hepatitis C, and on which we're going to show how using mathematical algorithms, we can calculate the impact of policies and changing those policies in each country in terms of achieving elimination of this curable disease.
So you just said that digital health has the power to change governments.
Yes, it has to have that power.
Big one. Thank you so much.
So, just to say, Sustainable Development Goals, as was mentioned here, are achievable. but they have to be translated. The SDGs are only useful if we translate them to the local level, and everyone is saying we can't leave anyone behind, so we should use digital tools to get everyone involved.
I expect you working with us in the paper. Thank you so much. Thank you. So we unfortunately ran out of time. This is why I have to close this panel. Again, please participate in the call to action. How can you do this? Please ask Norman after the panel. And before we close everything, my biggest thanks to Susanne Pritze for organizing us, the little angel in the background. And applause to Susanne, the lady in yellow. She has done such a tremendous job making this all possible. And I also thank everyone here on the panel. And Norman, you are now invited to have the final remarks.
Yes, just a few words on the call to action. This is our board, like you saw Bart Simpson. This is our we draw. It is just a draft version, and it's more qualified in the actual paper. We will publish this on worldhealthsummit.org, and you're invited to kind of engage, give your comments. We hope that will kind of help us in the future to give some orientation for GIZ. It certainly will, and maybe other can join. We will kind of collaborate with the digital principles because this is kind of the guiding questions we kind of defined while preparing for that panel.
One remark from my side as an entrepreneur. In digital health, we always serve with uncertainty, but the same goes in medicine. You never know actually the result unless you measure it somehow. Okay. Depends.
And we're here, and the panel will be here now because there were many questions that couldn't be asked. Come here and ask us. Thanks for
look
being
at
in that
him
session.
and look at me. We collect the questions. The questions will not be lost, and we will also put them in the call to action as well. Thank you so much for joining us, taking part. Thanks to the panelists, and see you around.